Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm very pleased you could join me for the third segment. I'd like to take a few minutes to talk about eyelid rejuvenation, eyelid surgery, and what we can do to improve the appearance and function of the periorbital area. When I talk about the periorbital area, I mean the eyelids and the upper cheek and the eyebrow. And that's a perfect segue to discussing what goes on when I see someone in my office during consultation who is interested in eyelid rejuvenation. Step one, what we need to do is to look at the adjacent structures. When I look at someone's upper lids, I've got to look at their eyebrow and forehead as well. Sometimes the eyebrow can descend. That's called ptosis. The eyebrow can come down and give an illusion that there's much more extra skin of the upper lid than there actually is. So we need to look at the forehead and the eyebrow when evaluating the upper lid. When I look at the lower lid, in particular, people sometimes feel that their tear trough is deep, or they have bags or pouches, or sometimes the lower lid will have bags, as I said, or almost a sheepdog kind of tired look. I need to look at the upper cheek. The malar area, or the upper cheek, actually serves as the foundation for the lower eyelid. So what we need to do when I'm looking at someone's eyelids, and we look together, of course, we sit and examine a patient with a mirror so that person, he or she, can tell me what their concern is. We need to look at the adjacent structures, being the eyebrow and forehead for the upper lids, and of course the malar area or the upper cheek for the lower lids. So, what do we look for? Oftentimes in the upper lids, people will complain that they have extra skin, and that can certainly occur. Our skin does lose resilience. As we lose fat in our face as we grow older, we tend to gain weight or gain fat in our trunk. But certainly we do lose fat in our face as we grow older and are exposed to the sun. Some of that fat can atrophy, leaving less resilient and a little bit of loose skin. So, briefly, what we can do about brow ptosis or forehead ptosis, there are many different ways that we can elevate the brow and the forehead, and the glabellar area can be affected too. Now, the glabellar area is that area in between the eyebrows at the top of the nose, or the nasion. Now, before I get to surgical treatments, I'd like to talk about Botox. Many of you are familiar with Botox or botulinum, Botox A. What that is a muscle relaxer. That's administered with a needle. It's an injection. What we can do is soften the lines between the eyebrows in the glabella. We can soften the lines at the sides of the eyelids, oftentimes called the crow's feet or the smile lines. We can't make them disappear, but we can certainly soften them. Whenever I see someone who has deep glabellar furrows and they're looking like they're almost in constant consternation or disapproval, they'll oftentimes tell me that their coworkers or family members will frequently say to them, "Are you angry? Are you upset? Did you have a bad night's sleep?" When in fact they're feeling just fine and relaxed. But when people have glabellar furrows, that can give the appearance that they're tired or angry or need sleep. So Botox can be very effective for that area even before we consider operating. Now, the sides, or the so-called crow's feet or smile lines, can also be treated very well with Botox injection, and that can be done right in the office. Oftentimes what I can offer to a patient is a microbrow lift with Botox. Now, very briefly, there are muscles that depress the brow. Those are the depressors of the brow, the corrugator and the procerus in the glabella, and the orbicularis oculi is a muscle that brings the brow down as well. It also helps to close the eyelids. The main elevator of the eyebrow is the frontalis muscle in the forehead. That's the muscle that helps give us those transverse horizontal lines in the forehead. So if we selectively make the depressors make those muscles relax, and allow the frontalis muscle or elevator to take over, then people can actually get a micro brow lift. Now, my preference whenever I surgically elevate someone's brow, or even with Botox, is to elevate the lateral brow more than the medial brow, in particular in women, because the ideal female form, the ideal beauty form for the female, the lateral eyebrow, or the part of the eyebrow closest to the ear as opposed to closest to the nose, that portion should be peaked. If you flip through the glamour magazines, all the models have a full upper eyelid, and the female models will have a gentle sloping upward to the lateral peak, and then sometimes a horizontal position, or sometimes even slightly coming down. That's quite universal for the attractive glamour models. Now, for the male, in our society, for men, the actors and male models, etc., oftentimes a horizontal low brow will be a sign of strength and masculinity. So I'm very careful when I'm doing Botox to elevate the brow, or even surgically elevate the brow in a male. So there are different ways we can elevate the brow. Now, when I look at someone's upper lid, I look at the amount of skin, see if there's extra skin, and also I like to see if there's puffiness or pouches. Oftentimes, as we grow older, the membrane that holds the periorbital fat in place, it's called the orbital septum, will sometimes get lax and allow the fat pockets to protrude through. That's called pseudo-herniated fat. It's not a true hernia, but as that membrane gets a little bit weak, the fat pouches will start to push through. Now, that happens particularly near the nose, the medial aspect of the upper lid. It can now also happen in the central part of the lid. Now, laterally, it can happen, when I mean laterally towards the side of the lid, but we've got to be very careful because the lacrimal gland is in the lateral third of the lid, and the lacrimal gland is one of the main tear producers in the eyelid. Years ago, there were procedures described to push the gland back, or even to remove a portion of the gland, but I think we need to be very careful about changing the tear production. So I'm very conservative when I do surgery for the lateral third of the eyelid. So again, we are good about addressing the position of the brow. We're very good about taking care of the extra skin in the upper lid, and we can also effectively minimize the puffiness or pouches of the upper lid by sculpting fat, removing some fat, and sometimes improving the strength of that orbital septum, the membrane that keeps it in place. Now, when I talk about fat of the lids, it's not because someone is overweight or obese. We all have periorbital fat. That's fat around the eyeball that cushions and helps lubricates and protects the globe. But we have a far greater amount than what's necessary. And as I said, that orbital septum keeps it in place. In some families, it allows the fat to kind of protrude through. And that can be very greatly helped by a blepharoplasty or eyelid tuck. Now, if we are to look at the lower lid, as I said, we need to look at the malar area, or the lower cheek, or excuse me, the upper cheek, which serves as the foundation for the lower lid. Oftentimes people will come in and say, I have these bags of skin. We need to be very careful, very judicious with removing skin from the lower lid, because people don't have as much skin in the lower lid as they think, or they don't have as much extra skin as they think. As I said, we need to look at the cheek. Sometimes a conservative malar elevation will help improve the support of the lower lid. And then, of course, very conservative, very judicious removal of skin from the lower lid can help. But mainly, what we do for the lower lid is to address the bags or pouches. Predominantly, that's fat. The septum, again, the orbital septum can help the fat stay in place. In some families, for an unknown reason, that membrane or septum gets lax and the fat can start to push through or protrude through, and thereby presenting with what people commonly call the lower eyelid bags, and makes them look tired. Now, I do want to emphasize something, and this is important, that malar pouches, or the fluid collection that some people get, especially women, in the morning, is a collection here at the upper cheek and malar area, and that is not the same as a lower eyelid bag or lower eyelid pouch. The first treatment for malar edema, which is fluid, is not surgery. We like to, in the office, teach mainly women, but some men get that as well, how to minimize the malar pouches in the office. And that's primarily with head of bed elevation and icing, and sounds odd, but sometimes preparation H can help, and by compression, that can treat those fluid collections in the malar area. But I do need to emphasize that malar edema is fluid, and the primary treatment or the first line of treatment is not surgery. However, we can greatly help with the lower eyelid pouches themselves by sculpting the fat, removing some, and strengthening the membrane. Now, the tear trough, as I mentioned before, is that groove that can get fairly obvious and fairly deep that lays between the eyelid and the nose. We can call that the nasal jugal groove or the tear trough, etc., or the eyelid nasal groove. Now, as the lower cheek starts to pull and as the tissues around the lower eyelid get lax, that tear trough can get quite prominent. Now, there are different surgical maneuvers. Sometimes we fill the trough. Sometimes we can do a little conservative release of the tethering ligaments there. Sometimes I can do a little modification of the muscle, the orbicularis muscle. There are different treatments for the tear trough, and or fillers or fat can be placed there. But all the treatments have to be custom designed. I think eyelid surgery, especially the lower eyelid surgery, is not a one-size-fit-all area. It must be custom designed, and an individual approach must be designed for the patient based on sometimes surgery or non-surgical treatments, etc. Now, I do want to say something important about Botox. I mentioned something about being unable to treat the malar edema. That reminds me to talk about with Botox, there are two things that all patients or people need to be aware of. That about 4 to 5% of people who get injections of Botox around the eyelids nationwide, 4 to 5%, might get a little bit of a lazy eyelid. That's when the upper lid hangs down a little bit too much. That's a temporary finding, and when that happens, I tell my patients, if it happens, I need to hear about it. I want to hear about it because we can treat that with eye drops, something called an alpha agonist that we can get over the counter. So there's a medicine, some drops we can give to counteract the temporary lazy eyelid or eyelid-ptosis that can come about 4 to 5% of the time nationwide with Botox injections. So of course, it's important to emphasize to people that there can be side effects and that we want to be aware of them if they occur. So again, for periorbital evaluation, before we do any type of eyelid treatment or surgery, we need to look at the eyebrow position. As I talked about, I like to primarily elevate the lateral brow, or if I do a brow lift or forehead lift, I like to elevate the lateral brow, especially in a female, more than we elevate the medial brow. There are many different ways to do that. Oftentimes I'll do that endoscopically. We make very small incisions in the scalp, hair-bearing area, and we put in a little endoscope. It's like an arthroscope, almost like a little telescope, and we can slide down, strip the muscles, weaken the muscles, identify the nerves and vessels, and elevate the brow that way. Oftentimes I'll make a short incision in the hair-bearing temple area. That allows me to slip down and elevate the lateral portion of the brow. And oftentimes I can slip down and lift the malar area too. That's a mid-face conservative or malar lift. And that can be done in the office or in the surgery center or at the hospital. Now, in the couple of minutes we have left, I want to talk about the eyelid position. Now, we can affect the eyelid position with something called acanthoplasty. We can affect the lateral canthal ligament or the medial canthal ligament. That affects primarily the lower eyelid position. Now, as I talk about eyelid position, when I look at the lower lid, if I see that the lower eyelid is coming down too far, that can lead to increased scleral show, or if a person has poor tone of the lower lid, sometimes I'll recommend acanthoplasty to improve the position and improve the tone of the lower lid, improve the support. That can be a very important adjunct. Now for the upper lid, I want to mention what we mean by ptosis. I talked about lazy eyelid that can occur. Now, ptosis is something that we need to talk about. We have time to talk about briefly, but I need to address those issues in the office whenever we're considering eyelid surgery. People can develop ptosis with age or from an injury, or sometimes with an injury or tear in the muscle that lifts up the eyelid. Upper eyelid ptosis or true ptosis comes when the position of the eyelid actually obstructs the vision. It can actually come down and interfere with the amount of light or an image that's coming into the pupil. That's different from lash ptosis. Lash ptosis is when there's so much extra skin that it actually rests on the eyelashes itself, and that can actually interfere with vision. A person can often document that with a visual field obstruction test done at the eye doctor's office to allow their insurance company to help cover that. 4 things need to happen. First of all, a patient needs to complain about the visual field obstruction and complain about what's interfering. It needs to be obvious and evident to the doctor on physical exam. We need to be able to see it on a photograph. And then the 4th parameter is to get a visual field obstruction test. And that can be done at the eye care professional's office. So again, we talked about the position of the brow. We talked about the malar area and the upper cheek being the foundation for the lower eyelid. We talked about affecting a little bit of extra skin and the lower eyelid pouches. And in the upper lid, we talked about affecting the bags, the puffiness, and primarily the extra skin. People will come in to my office, and it's one of the most common complaints that I see. They feel that their eyes are tired looking, they feel that they have bags or puffiness, and I think doing a careful exam, a careful non-rush consultation in the office can be very rewarding because we can design a custom approach for each individual patient. If you have more questions about eyelid surgery or any part of plastic surgery, I am Dr. David Morwood. My number is 831-646-8661. That's 831-646-8661, or go to the World Wide Web, drmorwood.com. That's DRMORWOOD. Once again, this has been your health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. Thanks so very much for being here today. I hope you tune in again soon. Thanks so much.
Making your life a more healthy one.